All right, everybody. So here there are different groups of people. So we have those who have exams tomorrow on the 9th, a lot of you sitting in these 2 days. And then there's quite a lot. In the middle, there's not many people. Then you have a lot on the 20 plus and above. So this one will be a bit for everyone together. It'll be a mixture a little bit. So just bear with me. And some information you might know already. So just bear with me. I'll finish really quick and then take all the questions. All right. So first of all, for those of us who do not know how the exam day is, I'm going to run through you really quickly how things are on the exam day. On the exam day, it's very simple, very basic. You go to the AMC center, you wait on the first floor. When it's time, there'll be a marshal who comes down to fetch you, and then they bring you up to the third floor, if I'm not wrong. And that's where you meet. I mean, usually a lot of people tend to gather on the first floor. Now, one very big advice I'm going to give you is try to stay with yourself when you are on the first floor. Now, the reason is because the more you talk to people, some of them are very negative. Okay, I'm not saying offense to anyone. Some of them are very negative in a way where they're very angry with the AMC sometimes, or they're not happy with the progress, or they haven't studied things, and then they're going to come and ask you. They're going to confuse you. I remember when I was sitting down there quietly, a few people approached me and started asking me for mnemonics and asking me like questions. And I was like, I started having a low-key panic moment. So I walked away. I replied those people and then I walked away. Now that's going to mess up your mind a little bit, and you don't want any kind of panic before the exam. So just try to be with yourself, drink water, stay calm, avoid the negative conversations. So when you go up in the second and the third floor, once the marshal has brought you, you need two identifiers. Please don't forget. Better to use your stethoscope, your own stethoscope, because you're more comfortable with your steth, especially when you need to change from bell to diaphragm, you're more comfortable with it. And a lanyard will be given to you when you reach the third floor. So you show your identifiers to the counter. They give you a lanyard. The lanyard will have your name and your starting station. So, which means right from the beginning, you know exactly where you're starting. You know if you're starting from a rest station, or you know you're at a station from station one or station 10. Now, the one key thing about this lanyard is this lanyard can get a little bit annoying because it's going to hang all the way in front. So, I've learned this from one of my friends where what she used to do is whenever there's a physical examination station, she very smartly, very swiftly, and cool. It didn't even feel like she was doing it. She very quickly just shifted it backwards, so she just showed the lanyard to the examiner. Once you're starting the station, she just shifted it backwards and she starts the entire station. So when you're doing physical examination, it doesn't interfere. So imagine you are trying to lean forward to palpate something, and then this lanyard keeps falling down and hitting. These are very practical problems that happen that we don't really think unless otherwise you have been in the exam before or you have practiced in the real life circumstances with this. So that is something to take note. If it comes to you like a habit, fantastic. If it's annoying to you, just shift it back. And there are also times where you remember lanyard and steth might start getting stuck with each other. So be very careful. If you're wearing a collared shirt or collared tee, up the collar, put the lanyard under that collar, and then push it down back because your steth and lanyard get stuck. When you go to take it out for if you need your steth, you're going to panic. So if the one thing to understand about this exam is this, we will panic. Panic is always going to happen. But now it's about planning how you want to panic minimally. That is the only thing we can do. Panic is existing, minimal panic, how to come back from the panic. And the more our brain knows that, okay, this might happen, our brain will be like, okay, I'm not so scared because I know love said this is going to happen. It happened. And now you already thought of how to manage it. It was not an unexpected situation where your brain panics. Okay, so everyone is then given a locker. So depending on the afternoon exam starts a bit more later because you once they need to get all 20 people in, and then they release the all the other candidates from the exam, the first session candidates, and then they go for lunch and then they take a break and then they invite you in. So from the time you enter, if you're an afternoon candidate, you gotta wait an hour and a half. So you are allowed to hold your reading material. So no digital copy, but you can hold on to papers and books if you want. So if you do want, yes, you can do that. I would recommend maybe just words if you like key points you want to remember, you think you might forget. But to be very honest with you, do you think, I don't think the brain will be able to absorb anything at that point in time. Nothing is going to go out anymore. Your work has already been done. All right, your work has been done. So trust that it's been done. Now you need to chill the brain a little bit so that the brain brings it out. If the brain is on panic mode, the brain is not going to be able to bring out everything that you need. So the key should be calm down your brains. That would be the best. And now when I want to talk a little bit about the food and meals that you need to have, please try to eat food which gives you a low sugar release, which means your granola oatmeal bars are really good. The honey one is very good. Honey is a low GI index food. The reason why I'm talking about this is because if you're going to eat something very high sugar from the beginning, yes, your sugar is going to spike. up high. You're going to get adrenaline really well. But then station number 10, you are going to dip. Your brain is going to get tired for the remaining 10 stations. So it's very logical, very practical. People don't think about it. People don't consider this, but try to eat food which lasts for long. So oats are slow digesting food. Your porridgey kind of feels also your quinoa. All these are very good food. So read a little bit about that plan. The thing is, you need to enter with a strategy. You can't just go empty tummy. You got to fill your tummy, get that sugar, keep sweets in your bag. You can't carry any kind of food with you on that day, but you can put it in your bag if you need to run and go get it during the exam, during the rest stations. A marshal will help you to go and get it done. All right. Now, I talked about the waiting area already, so now the exam itself. So in the exam itself, do I have a picture of it? No, I don't. Okay, so basically you'll be standing outside your rooms. Outside your room, there'll be a small TV screen. So remember this, only in your first station will you get 2 minutes. Every other station, your 2 minutes starts when your 8 minute finishes of the previous station, but you are still in the room of the previous station. You are still saying thank you to the examiner. You're still saying thank you to the role play, and then you are running out of the room. And then you're going to read, which is why if you have time, if your exam is 20 plus July, please, please, please only read for 1 minute 35 seconds. Done. Tops. Do not waste time. And also when you read presentation time, 7 minutes 35 seconds or 7 minutes 40 seconds. Why is that so? Because every time you enter the station, this is how your room will look. Every time you enter the station through that door, you need to sanitize your hands. Now the sanitizer was spoiled in May. So in March, sanitizers were working. In May, the sanitizer spoiled. In June, the sanitizer is working again. I checked with all the different candidates because I'm like, why some people are sanitizing, some people are not. So if the sanitizers are working well throughout all stations, examiners will ask you to sanitize your hands. So you have to sanitize your hands, and then only they will look at your card, they'll take your attendance, and then they'll be like, this is your role player, your player's name is Tim. Do you have any other questions? Now, when they ask you, do you have any other questions? This is when is your time to ask about hemodynamic stability if you are concerned about hemodynamic instability. That is your time to ask. And as I always say, examiner gives you 3 responses. Patient is hemodynamically stable. If there is a PP asking station, a task in that particular station, an examiner will say you will find out, or examiner will ask you, what do you want to know? And if the examiner asks you, what do you want to know? Please throw, I want to know the vital signs, and vomit out your blood pressure, heart rate, respiratory rate, O2 sets in a line. Just vomit it out. Examiner will tell you. You will identify where your patient are. But usually, as I always say, patients are usually hemodynamically stable. If not, you can't do much in the station. Now, when you enter the room, please don't worry. On the screen, as you can see, your task will be there. There will also be a printed task sheet on the table as well. And the examiner will usually be behind you. So now the tricky part comes is when you're asking for PIFI, or when you have your, what's that thing called? PIFI or MMSE presentation. You ask the role player all the questions. The chair is a rolly chair. So roll your chair, face the examiner, and then present your MSc. So you got to move a little bit when you're doing this. So examiner is usually behind you. Unless they can't hear you, they come near, but you don't really look at the examiner's face. Any question about the layout? And you always have a pen in your station. There will be tissue paper as well. So for those of us who are worried about the sanitizer, there is a tissue paper on the table itself, a tissue paper box. And you also have tissue papers at the side where there's, beside the sanitizer, there's a little box where tissue paper will come out. So you can always wipe your hands. If you forget to throw the tissue paper, don't worry. They will fix it. Doesn't matter. Leave the room once you're done. Don't bother cleaning up. I mean, you can be really nice, but that will make you forget things, okay? Any questions as of now? So any questions about the structure? So for those who just joined very quickly, this is how every room will look like. Anyway, this session is recorded, so you guys can run through back again when you can want to watch this. So I want to take questions that you guys had. All right, so just remember, every station is just another patient for you guys. You guys have seen so many patients in your life. All right, so it's just another patient. Take it as a consult. Go in, give it your best shot, come out. Don't think about it. I know it's very easy to say. I have struggled before. I'll be like, oh, I missed this, I missed that, I missed this. And then I start reading my next stem, and I only have another, 1 minute to read my new stem. And I'm like, oh, it's a new station again. So continue pep talking yourself. Like I always told myself, okay, focus on this one. You can't focus on the next one. And I remember even during my exam, I had one station where I had water in my eyes because I messed it up so badly. I had water in my eyes. I couldn't even see the new stem. So I had to wipe off my tears and continue on. So these things happen. It happens to people. So don't panic. Just keep telling yourself, focus. talk to your brain, all right? It's really going to help. One day I do have a brain gym session that I do usually, but no time for brain gym for you guys. August people, maybe I'll work on a brain gym session. All right. So a couple of things. Now, when it comes to, you guys asked about breaking bad news stations, burn assessment, and then I'll do psychiatry for you guys. So when it comes to breaking bad news station, please, they usually use the spikes protocol, which is setting up the interview, getting the perception of the patient, and then getting the patient to invite them to hear you. So I'm sure you guys know that. You don't 100% have to say that you're going to do the spikes protocol when you're doing it. Just ask them, how can I help you today? Do you know why you're here? So usually some of the cancer cases, they don't come with a history taking. But now the confusion is this, if there's no history taking, can I ask questions? So you can't ask history questions, but you can always ask the patients, how can I address you? And do you know why you are here today? Now that's not a history taking station. There's no presenting complaint, right? That you're going to focus on and ask about it. So yes, you can ask them, how can I help you? And what are your concerns for today? Or do you know why you did the blood test previously? And what do you think you're expecting from it? What did the doctor tell you about it previously? Now use that as a starter, use that as a rapport, and then move on and continue breaking your bad news. And of course, ask them if somebody's there with them before you start. Prepare, make sure there's water and tissue on the table. Give the patient time. Now, the key sentence, if your patient starts crying uncontrollably and you're annoyed by it and you only have 8 minutes to finish the station, the sentence is, what is it? Now I forgot the sentence. Yes, would you like to do this today or would you like to do this on another day? So would you like to have this consult today or would you like to have this consult on another day? Now, at this point in time, the patient has no choice but to tell you, yes, doctor, let's finish this today because they know you are in an exam. So get these key sentences out to guide you. And as I always say in the exam, don't let the role player take over the consult. You always have to bring the ball back into your control. Bring the ball back into the court. You are the main person in the station. So you run the show when you are inside there. So bring back, make sure you are in control. Every time you feel out of control, think of the things that you want to say. For example, in the psychiatry station where you have the schizophrenia patient who goes around hitting the cockroaches, the key sentence to use in that one would be, we will get a nurse or the cleaner to come and clean up the room for you, or we could go to a different room if you would like. Patient becomes okay. So find these key things, bring the patient back to your control, continue the consult. Don't remember, you can always get them back in control. Don't worry. You have it in you. You've practiced so much, you have it in you. But if you panic, then you lose that. So stay grounded when you're doing your stations. Now, someone asked me about the papillary, I think you asked me about papillary carcinoma or BCC. I'm going to run through very quickly to you how the stations come. Now, for your BCC, SCC, and melanoma stations, there's two types. One is just telling them that, oh, we did a biopsy for you, and then you have this condition. But most of the cases come with re-excision. So patient comes, the margin is not complete, and you have to re-excise. For your melanoma, you look at the depth of it. Prognosis of melanoma is based on the depth. Now, for the other ones, it's your margins, and you have to remove them more. So when you go in for re-excision, the lady say, oh, I'm very concerned about the scar. That's when you have to talk about your Mohs surgeries. I'm going to throw out words, just listen to me and catch them, okay? So you're going to do your Mohs theory, Mohs surgery. You're going to do your photodynamic therapy. You have your cryotherapy. You have the topical imiquinoid, and you also have your radiotherapy. So these are different other ways you can tell them that, hey, I know you don't want a surgery, but we can do the Mohs surgery where we remove bit by bit by bit. As we remove each side, we're going to send it in. We're going to send it to the test in the lab to see if there's any active cells, active cancer cells. So in that way, we remove minimal tissue. And the key thing in this station, in your re-excision, is to say that surgery is your only definitive, okay, confirmation of removing your cancer cells. Because if you do a radiotherapy or if you do topical imiquinoid, you can never be guaranteed that you have removed actually all the cancer cells. And remember, if you have any kind of cancer stations, remember to give them their red flags at the end, whether it's your this kind of counseling stations or someone at higher risk of having cancer, let's say a peptic ulcer cancer as well. Give your red flags at the bottom: loss of weight, lumps and bumps, loss of appetite. Come back to me. If you think the example for headache stations as well, if you think the pattern of your headache is changing, come back to me. So don't forget your red flags at the end. Let me tell you, you always have things to talk about until your 8th minute. You are never not going to have a time where you're silent, unless otherwise you did it very well. You are a fast speaker. I'm quite a fast speaker. I tend to finish a little bit earlier because I speak really fast. But if you're not a fast speaker, it's very highly unlikely you will finish very, very early. So which means you have time to talk. And anytime you're confused, always told you, have your bag of tricks. If this person is above 60 years old, above 50 years old, talk about all your screening questions, colon screening, mammogram, breast screening, CST. Bring that out of your bag. Okay, you want to talk about elderly care, about how they're being cared for, any support, bring that out of the bag. So these are things to throw out whenever you get confused. So have that ready things in your bag. And of course, SADMA is something that if you get stressed in that station, you do not know what else to ask. SADMA comes to everybody very easily. So I know it's going to affect your structure, but I would prefer you to ask questions instead of just staring at the patient very awkwardly and just stare there trying to think, because that's going to make your panic worse. So ask your brainless questions. So let's say, for example, Sikora and Socrates are actually quite brainless questions if it's for pain, because you're just going to go down the line. You know your mnemonic really well. So you don't have to really use your brain. You just have to listen to the correct answer. So you can use that as your safety bag, or SADMA as a safety bag. Or if you are a bit more chiller, you can go, let me just recollect my thoughts a little bit. I really want to understand what's going on. So let me just read what I have, and then we'll go on with the consult. That is also a method if you are confident with the pause. All right, so see which method works for you and which strategy is going to work well with you. You should be good to go. All right. Let me find the other BBN station. So the other one was prostate carcinoma. So for prostate carcinoma, you need to know the Gleason scoring and the explanation of the Gleason score. So if the Gleason score for your prostate cancer would be how aggressive, right? Like you look at the character of the cells and you see how aggressive they are in terms of spreading. And prostate cancer is one of your slowest spreading cancers. So that's why you prefer the wait and watch method, the active surveillance. That's number one. And the reason why you prefer wait and watch over the other options like surgery is because surgery has its own um, cons, which means you have the post, the operation itself, the bleeding and all the operation negatives that can go wrong. And then you have the post-op problems, which is your erectile problems, your urinary problems, your infections. All these things can come after. And if you weigh the costs and benefits, people do prefer just doing the wait and watch instead of actually going for the surgery. So keep that in mind. You also have radiotherapy when it comes to prostate cancer, but you're just afraid of affecting all the parallel organs when you're doing radiotherapy. And then you have hormonal treatment as well. For the hormonal treatment, you can give them medications to suppress the androgen. All right, so that, and of course, last resort, very, very last resort, but okay to mention, some people do remove their testes because testosterone increases the edge for the cancer to grow. So they do remove their testes, but that is really, really, really your last option. Please don't mention that. Admit that it's an option because you got to give a very good holistic carcinoma picture, but don't say that I'll be cutting off your testes. Okay, so please don't tell him that. So that is your prostate cancer. Now I'm going to very quickly go into the thyroid carcinoma case. So the thyroid carcinoma case comes as the lady who doesn't know she has cancer. She comes in because she just had a little lump, and then they did a biopsy and they realized it's papillary carcinoma. So again, first, before you start any of the stations, give yours. I'm sure you guys are good by now to breaking bad news. So give the very nice fun stuff. Calm them down. Ask them why do they think they went for the procedure. And if you're a really good doctor, if you have time, think about it. Someone just went for a biopsy. Aren't you going to ask how you're doing? Aren't you going to ask how's the wound? Very simple. In a real day, you would have done it. But because this patient maybe doesn't have a wound, or it's a fake patient, you don't think about it. But you on a normal day would ask the patient, hey, how was your wound? Is it healing? Is it fine? Any complications? And then you go on with the consult. The patient will be like, oh, this doctor thinks about me. This doctor feels about me. So this question, again, I would like to repeat. When you have your ulcer case, it's the ulcer case in the schizophrenia for psychiatry, and your borderline personality disorder case where the girl cuts her hand and you got to go and check on her because you need to discharge her. Many of the candidates I've done these cases with forget about the fact that this patient was actually injured or something is wrong with this patient. They just, because you look at the recall, you know the answer of this case, you go straight into your mood, sleep, appetite. You're not even bothered to ask about the ulcer or whatever's going on. So take 20 seconds to say that how is your wound? Is your hand painful? How is the wound doing? Is it healing? and then move on. So that shows, that builds your approach to patient, that builds your rapport. You are done with rapport. You have gotten a 6 or 7 right by asking that question. You can move on the content of it. And when you get that slow conversation going on, it gives you confidence. You will actually see the patient ease up a little bit with you, a bit more comfortable with you when you do that. So try doing that if you have time. If you do have practices with your role play partners, consciously do these things. Until you consciously do these things, it's not going to become habit for you. Now, back to the papillary carcinoma with the thyroid. So once you've explained, they're going to ask you what are the complications of the surgery, or what complications the patient might have in that case, and they also ask you the next step of management. So think about it. When you talk about, sorry, any questions, Ujala? No questions? Okay, I just thought I heard someone. When you go to explain what are the next steps in management, before you do any kind of surgery and tell that, oh, I'm going to send you for surgery, very simple things that you do. You would bring the patient in for a consult. You would do some bloods. You would check the lymph nodes to check for any kind of mets. You would also be checking in ultrasound to see how the patient might be doing at that point in time. So these are things that, sorry, someone's mic is on. Can I trouble that person to turn off their mic? Okay, I've done it. Never mind. Okay. So tell them that before we start the process, we would be doing a check first, doing an ultrasound to see how extensive this papillary carcinoma might be. And then you mention about the surgery options where you have subtotal thyroidectomy and total thyroidectomy. So you remove either a lobe or either you remove the entire thing. And before that, explain to them what the thyroid is or where the thyroid is. It's a little butterfly gland that can be found here at your throat. Point to yourself. If you don't want to, it's hard to draw. It's a waste of time to draw in some stations. So point to yourself. It's roughly around here. You can actually feel, if you touch it really well, there's a butterfly gland that we have. It controls our body and produces the thyroid hormones that we need. So that's why, because of this lump that you have, we might need to do a total removal or just one lobe of it. But the surgeons will be deciding on how the procedure will be. However, let me share with you a little bit more about the complications that you can have and the other things we'll be doing for you. So if we don't do a surgery, we will be doing your radioactive iodide. We can do radioactive iodide for that patient. All right. And then you explain about the complications of the surgery, which this patient, it has to go on thyroxine for life. All right. Thyroxine for life. Your patient, parathyroid hormones will be removed, calcium for life. So these are like long-term problems that the patient would have. Patient would also be having possibility of your post-op shortness of breath with the hematoma. And also you have your recurrent laryngeal nerve complications during the surgery as well, where it could lead to voice hoarseness. So these are all the different ones you can explain to the patient. However, I'm very sure that the surgeons will be very experienced. So give the problems, sandwich it back and say that I know all these things exist, but we still do a very good, careful job when we do the surgery, and then you continue your consult. And then, of course, you would also be doing follow-up bloods on this patient very often because you want to just check the thyroid globulin. Oh, okay. All right. Now, any questions about your melanoma, prostate, and BCC, SCC thyroid cancer cases? I will be sending the Ollie actually has very nicely typed for us the margins that we need to remove and the rules. So I'll send you guys that message once I'm done with this session on the margins to look out for with the prognosis, whether it's a margin or whether it's a depth for your melanoma cases. So I'll send that through. She's typed it up very nicely for us. All right, so next I'm going to move on to the burn assessment station. Now with the burn station, many of you guys are confused. Now the station comes in a couple of ways, but the common one is where it comes together with history taking. All right, and one thing to know, if someone has comes in with a burn, a baby especially, someone who's younger, you are very concerned about if this fares a negligence or is this an abuse. So keep that thought in your mind, negligence or abuse. Of course, you do your clinical questions, but always trying to go back to, are you a happy family? So key questions to ask if you have history taking in your burns. I'm sorry, I didn't actually type them down. I only have written them down, but I will, let me just write down, send you guys a picture of burn management. Okay, very easy case, not a very difficult case, easy scoring case. Your TBSA, your total body burn surface, your total burn surface area is usually always need to admit observation. All right, so when you're doing the history of your burn, ask about ABC first, airway, breathing, and circulation. So in the airway, you're going to ask whether there's any signs of airway burn. Where is the burn spot? So is it burned in the trachea area? And was there any inhalation that happened? All right, and where exactly is the spot? Then check for breathing, see if the child can talk, say a couple of words, and then you need to check for circulation. So those are things that you will do. So hemodynamic stability first in this station, then move on to the history taking. Ask them the time of injury, ask them how it happened. So what exactly happened, what was going on, and ask them what has been done. So what kind of first aid has been done? Ask them that. And then check about whether there were other injuries in other parts of the body. The reason why you do this is because you're thinking of child abuse and negligence. So usually in these cases, there might be more than one injuries in this thing. So just check out a little bit on that. Ask about your tetanus status. So tetanus status. And then you move on to do the assessment of the burn itself on the burn depth and the total body surface area. So usually if the burn percentage is more than 10%, so far the burn percentage is given to you. So if it's more than 10%, you have to give IV resuscitation of your Hartmann's solution, all right? And just do a urinary catheter to just see the input-output balance that's going on. And of course, you're going to give your analgesia for the pain of the burn. It's going to be really painful. You're going to make sure ABCs are always very good and high. And you're going to do bloods, basic bloods. You're going to do your hemoglobin. You're going to do your electrolytes. You're going to do your blood sugar level and your VBG. I'm going to repeat. You do your hemoglobin, your electrolytes, your blood glucose level, and your VBG. So these are the different tests that you will do for investigation and the burn assessment. So usually always is admission for this one. I'm admit and take care. So just double I have a picture of the TBSA. In fact, I'll tell you, Connor is a very good picture for the burn surface area. Any particular questions, anyone? If not, I will move on to doing psychiatry really
Can you
quick.
repeat the test?
Hemoglobin, HB, electrolytes, blood sugar level, VBG, venous.
Oh, thank you.
And of course, check for AB, constantly check for ABCs. Tell them that you will be monitoring for ABCs. Oh, sorry, guys, I forgot. I had a slide actually. Okay, so I put STIs under BBN. Well, it's been a very big debate if STIs are under Breaking Bad News Station. So, but to me, I'm like, I guess it changes their life a little bit. So just ask them if anyone is there with them, and then you tell them it's not as dramatic as your thyroid, prostate, and your others, but just give a little ask if you want to. Yes, I will be tapping on MMSE towards the end, okay, because I'm doing psych. Okay, so thyroid, we did all of this, yeah? So STIs, just be a little bit careful. Remember, chlamydia and gonorrhea, chlamydia. Okay, since we're all free, chlamydia, key points, throw me in the chat box, please. Medication, give me your antibiotics, give me your contact tracing duration, give me your, what else? Key points, chlamydia, gonorrhea cases. Give me your key points. Chlamydia first, because gonorrhea met's a little bit different. Shoot in the chat box. These things should be at the tip of your fingers. Chlamydia management, everybody. Chat box. Fantastic. What about contact tracing for gonorrhea? Contact trace for gonorrhea. Fantastic, Azito. So please remember, in pregnancy, gonorrhea 2 months. What is the one thing we are forgetting? These are what kind of diseases? What kind of diseases are these? I'm waiting in the yes, perfect. Thanks to notify diseases, all right. And for those who are concerned for chlamydia doxy, if you have a lot of time to talk about the side effects on how it has light sensitivity, photosensitivity for doxy. So you can talk about that, and then you can talk about how doxy also gives you GI issues a little bit. And yes, you do your repeat test. So gonorrhea has your test of cure. You're going to test in 2 weeks. The remaining ones you're going to test 2 to 3 months later because you have your HIV, you're afraid of dormant HIV. Now you're also going to get them to come back 1 week later for compliance. So compliance on two things: compliance on medication, compliance on whether this person actually did the contact tracing. Because first you're going to let them handle the contact tracing. If they don't want to tell anybody, then you take it into your hands. But give it to them first. Responsibility is theirs and the anonymous ones. Fantastic. You guys are on a roll. I really hope you guys get STI stations. All right. Sorry, someone asked me this. So I put this down. I don't know who asked me, but these are different one-liners you can use. The thing is this, for all your Breaking Bad News stations, just memorize 1 or 2 lines and throw that because it's going to be a different role player every time. It's not going to be the same role player. Again, it's going to be a different examiner. So memorize a few which you feel might be good for you. Okay, don't usually I usually just say that, we will be here with you in every step of the way. So let me break it down for you. And then I break it down for the patient a little bit, how it's going to happen. So I'll just put the slide for you guys. I will be sending the slide, so no worries. You can get a second scan on this thing. All right, so now we are going to do our psych review. I'm a very quotey person, so I did put that at this point in time, it's not so much about learning new information anymore. It's about refining the way you deliver that information. And please, as I always say, trust your revision. You guys have studied a lot, and I know how much of effort we put into this thing. So I'm very sure you're not going to go there with a 6:30. You have done what you can with whatever family situation, whatever health conditions. I know it's not easy. Life happens all the time. So with what you have, you've done your best. All right. So go there and give it your best shot. All right. So I'm going to start from postpartum because that's a bit easier. I'm quite fast. Please rewatch the recording if you have problems a little bit, okay? Because I want to take other questions later on. So when we look at postpartum, remember postpartum blues. Anybody comes with you with a 6-week baby check or a 6-day baby check, however old the baby is, spend time asking the mom, how is she doing? It's a red flag. I always use the 6 B's and 2 C's. So your baby, how the baby is doing. Check the blues, bowel, bladder, birth canal, bowel, bladder, birth canal, and breast. So ask the mom if she's breastfeeding or not. Usually, if you get identified that the baby's mom is not doing fine, mom like, oh, doctor, I'm not doing fine. Baby's also crying so much. I don't think I'm a good mother. You know that this is going towards a psychiatry case because there is a case that came in the exam and it was an irritable baby. People said that it was infantile colic. People filled that station. Only those who passed were the ones who identified it was actually a postpartum depression case. So even though baby comes in crying, baby is irritable, check on the mom first. If it's less than 6 weeks, check on the mom first, then move on to HOPC. All right, and see where exactly the problem lies. So 7 days, usually it's blues, more than 2 weeks depression. And they also can come with psychosis with hallucinations as well. And the key thing to ask is it instructing you, whatever you are hearing, the auditory, are they commanding you or are they just talking to you? Because sometimes they are, so if it's either ways, hallucinations are still a risk depending on what it is. But if that thing is commanding them to kill the baby, now that's going to be a very high risk. You need to admit that patient. All right. Now, when we move on to depression, first of all, always remember psychiatry. You can only diagnose psychiatric conditions after you've ruled out all the other organic conditions. Psychiatry is an diagnosis of exclusion. So if you have your tiredness case, very common depression case is your tiredness case. And I know you have the entire hemiferoc. Hemiferoc is really long. I totally understand. And if you know that this is going towards a depression case, I always say rule out head injuries, rule out thyroid, rule out infections. These are your top few to rule out if inorganic causes in almost every single psychiatry case. Now, thyroid, why? Because John Murtagh says the 7 masquerades, all right? So John Murtagh has it everywhere. So thyroid can cause depression, depression can cause thyroid. So eeny, miny, any more. So just ask thyroid in all your psychiatry cases. Head injury, always there up there as well. Any kind of head injury, any kind of frontal lobe injuries can affect your personality. That can affect the way you think. So ask about head injuries and infections. Usually I ask that because fever, sometimes it can go into delirium as well. So ask that question. The other one for tiredness, I always add is the skin color changes because you kick out hemochromatosis and hepatitis and jaundice and all these things. So one question, kill more than one diagnosis and then move on to your depression questions, okay? Now, dysthymia, remember, it has to be more than 2 years to diagnose that. Adjustment disorder, any kind of change, all right? But these feelings will only be happening for less than 3 months, not more than 3 months. So please look at your definitions of your duration really well. Now, for anniversary grief, you need to remember they have to already be okay from the previous time the death happened, which means, let me clarify. If let's say this patient's mother died in October, right? They have to recover, they have to feel a little bit happier. And then again, 1 year later, next year, October, means let's say by December, they're okay, back to normal. Then next year, October or September, they're like, oh, I'm feeling sad, doctor. I see my mom. That is anniversary grief. But if this person from October, the day the mother passed away, from October to next year, October, the patient is still sad. Now, that is your depression. That is not anniversary grief. All right, so be very careful with durations. The patient must have recovered. They must have feel better before they feel sad again. That is a key point for anniversary grief. Anhedonia, please, major depressive disorder, know your mnemonic. Did I write the mnemonic here? Oh, I didn't. Sorry, there's a mnemonic for that. I'll put it in. Now, for the anxiety disorders, I use the mnemonic GPOS. GPOS to remind myself of all the various anxiety disorders that are out there. So, generalized anxiety disorder, we usually just ask them, are you generally an anxious person? We look out for symptoms. When you go for panic attack and PTSD and phobias, now, panic attack, please remember you have a multitude of symptoms that come up. Panic attack peaks in 10 minutes, subsides in 30 minutes. So, ask them about the various symptoms. Do not forget your ECG when you are doing a panic attack. If the patient comes with chest pain and palpitations in your management, in your office test, if there is, do your ECG because remember, organic first, then only your psychiatry diagnosis. So rule the big guys out. Then like, this is panic attack. Now, when is this panic disorder? Now, panic disorder is when the patient is already expecting the next panic attack before they even experience the first one. They're really thinking about when the next one is going to happen, what's going to happen, how am I going to feel, where is it going to happen? But they start confusing themselves about this. Now that is panic disorder. So know your differences really well. I'll talk about PTSD in the next part. I'm going to talk about OCD and OCPD. Your key differential factor between OCD and OCPD. OCPD people have no insight. They do not know what on earth is going on. So if you ask them, do you think you need help? No, doctor, I don't need any help. Nothing's going on with me. Why do I need help? And OCPD people, they are usually more perfectionist. They're very rigid with their the way they do things. So if you don't ask OCD versus OCPD question, it might be a critical error for that station. So I got OCPD for my exam. I did think it was OCD throughout the entire consult until I asked the key criteria between. So OCPD people have no insight. OCD people have insight. They know what's going on. They need help. They know something is wrong with them. OCPD people do not know what on earth is going on. They just know that something is going on, but they don't need help. They don't want to come to you for anything. OCPD is your obsessive compulsive personality disorder. Sorry, I forgot to mention. So OCD is your obsessive compulsive disorder. It's part of your anxiety cluster. OCPD is a subset of your OCD, where it's a personality disorder. And the key differentiating factor is insight. OCPD people have no insight. All right. Let me just open the chat box real quick. Okay, cool. Um, PTSD, I'll talk again. Okay, thyroid, again, asking every station. Substance abuse, please, every psychiatry case, there is always a story. You have to get to heads to get to the story. There is a trigger 90% of the time. There is a reason why something happened or why they are in this particular condition. It can be a divorce, it can be a breakup, it can be a death, it can just be an incident that happened. So I get that incident out of the way, get the story. So you got to go a little bit faster, but still feel like you're reassuring the patient and you're a nice doctor. All right. Now, body dysmorphic disorder, BDD, key thing, do not forget organic causes first. So if you have the breast case for body dysmorphic disorder, the key question would be, do you think your bra size is changing? People ask a lot of questions. Do you have back pain? I have a lot of candidates, do you have back pain? And they ask me, do you think you look big? Anybody commented? First of all, who's going to comment about your breast? First things first. Second thing, back pain, you can have back pain without having a heavy breast. It's not that heavy breast equals to back pain all the time, right? You can have back pain alone. So how will saying that, yes, doctor, I have back pain equals to big breast? So these are very logical things if you think out like that. Doesn't make sense. So why are you asking back pain now? Back pain is a complication of big breast. But does this help you in this station? No. The key thing would be, is your bra size changing? So even for the obesity cases where they think they're getting bigger, is your clothes size changing? Do you think it's getting tighter for you? Okay, so these are the questions you need to ask. For breast, ask about breast lumps, breast cancer is up there, discharge, mastitis, all these questions, abscess, fever. Rule out these ones first. And then after that, diagnose with body dysmorphic disorder. Check how many times she goes to the mirror. Look out for how has this affected her daily living and get the trigger out of the way. Now, for body dysmorphic disorder, people tend to forget. One in part of the management, you need to ask the patient to cover all the mirrors in the house. Remove the mirrors or cover the mirrors in the house. Remember that. I know many of you guys do not say that when you guys are practicing with me, but that is actually a part of the management of body dysmorphic disorder. And these patients, they usually might have previous episodes of BDD for other parts of the body. So they're like, oh, doctor, last time my nose is a little bit crooked, but then I don't know how come it became okay. All right. So try to ask them if any other body parts they have an issue with. What else important for BDD? Let me think. That's about it actually for body dysmorphic disorder. All right, so let's move on to PTSD. Again, another commonly occurring case. So I always use the mnemonic. So there should be a trauma that happened. You should be re-experiencing the symptoms. You want to avoid that condition. So many of these patients are like, oh, I don't want to go back there. When I go back there, I have these symptoms. I feel this, the whole thing replays and I cannot function. Okay, those are words that start using and identify that the month is more than one. So the incident should have happened. Only after more than 1 month can you diagnose with PTSD. Before that, stress disorder. After 1 month, post-traumatic stress disorder. All right, so but usually most of your cases are post-traumatic stress disorder. The one thing I wanted you guys to remember is your borderline personality disorder plus delayed PTSD case. People have been coming and arguing about what the diagnosis is in that particular station. The case where the girl with the pink dress, I don't know if you guys know, there's a recall which says the girl, the one who cut herself, and because she saw somebody in a pink dress. Now, the key thing to identify in that case would be, is she cutting herself because of the overwhelming feeling that she's having, or is she cutting herself because she's suicidal? Now, if she's suicidal, then fine, that is your suicide risk. But usually, your borderline personality disorder people are impulsive people. They do not know what to do when they have a lot of emotions going on. So she cuts herself because, doctor, I just felt so many things, doctor, and I just cut myself, but I don't want to kill myself. So she's not suicidal. It's just to relieve the inner tension that she has. That's why she cut herself. If you're not able to identify this, you can't get your diagnosis of BPD. And she's very impulsive, right? So you get that out of the story. And it's happened because of a delayed post-traumatic stress disorder. So there's two diagnoses here. Don't be afraid to give two diagnoses. If you think it's right, if you can justify it, give it. MSC, I will talk to you guys in a bit. Mania, please remember your mnemonic off the top of my head. Insight, grandiosity, I can't remember everything, guys, but mania question is not very common. It usually comes with the lady, she overspends. She breaks the law, she takes heroin, she goes into a whole mania episode. Key question when you're asking for psychiatry, how is your mood? If you ask for mood, the patient says my mood is low. Please ask, has it ever been high or have you had moments of high? You want to identify if it's mania, bipolar, or just depression. If she says, oh, doctor, I'm feeling low now, but yeah, I've had some highs, that equals to bipolar. So while you're asking mood, throw that question in. Have you had any highs? If they say it's low, if they say it's high, have you had any lows? Okay, because that will change your management. It's lithium. You're not going to give you SRIs. So very key. Psychotic disorders, I tapped you guys about schizophrenia, the different cases which are coming. Usually schizophrenia, most common is auditory hallucinations, but do dive into all your various hallucinations that are out there. There are patients who do not take medications. Try to think about why patients don't take medications. This is just not for schizophrenia cases, but overall throughout psych and med search. Usually they don't take because they're afraid of the side effects. They also don't take because they don't have enough money. So financial stability, or they forget. Very simple things why they don't take medications. So try to identify why. There are also certain psychiatry cases which says that the medication is not working for me, doctor. Now, if something is not working, first you check compliance. Second, you check if the dose is actually enough. So it might be a dosing problem. So you might need to increase the dose. So focus on why the medication might not be working and then continue your consult. All right. And for psychotic disorders, I put med side effects because of your risperidone. Gives you your milky discharge. All right, and you also have tardive dyskinesia. You also have olanzapine, which makes you a little bit bigger in size, so they don't like getting big. So olanzapine is one of them. You have clozapine, which gives you agranulocytosis. So know these little side effects of medications. Okay, personality disorders, I tapped on it a little bit. We'll go to alcohol, smoking, and counseling. Now, please, when you do alcohol and smoking and counseling, stick to your 5 A's as closely as you can. That gives you a very good structure. I did look at the handbook cases and the marking sheets. They do follow the structure quite closely, which is why I'm asking you to follow the structure. Ask about health questions in general. Ask them how they're doing. When you go to assess, remember, assess has dependence, tolerance, and motivation. Let me repeat, dependence, tolerance, and motivation under assess. And assess, there is a specific task in one of the exam questions where they specifically tell you to assess the substance abuse of the patient. All right, and that means you have to do tolerance, dependence, and motivation in your history taking. Focus on that, and then you give your diagnosis. So when you talk about tolerance, usually very simple. Do you think that you've needed to take more sticks, or do you think you need to drink more alcohol over the years? Has your consumption been increasing? So check that out. For your dependence, this is where the question changes in dependence. It's a bit different for alcohol, it's a bit different for smoking. For alcohol, you're going to use your CAGE questionnaire. You're going to try to identify the type of alcohol they drink. So what alcohol are they drinking? What is the pattern of drinking? Is there binge drinking? Do they drink early in the morning when they wake up? What is the gap between waking up and the time they drink? These are questions you ask for alcohol counseling. CAGE is very big. So CAGE questionnaire, I'll do it for you. Have you been trying to cutting it down? C, A is if you have any annoyed feeling if people call you out. G, do you feel guilty for drinking? E is an eye opener. Do you have to wake up early? Is it your first thing that you do in the morning to drink alcohol? So the other one people use is the audit questionnaire. So you don't have to do both, please, because you're doing the same thing. So I have seen candidates who do both audit and CAGE, and I'm like, you're achieving the same thing. Why are you wasting your time? So just pick one. I prefer CAGE because I'm not very good at math. I'm sure by now you guys know I'm not super good at math. So I don't like audit score because you have to calculate it. So I'm not very fantastic at that. So advice, arrange, assist, very simple. So if this patient, with your motivation question on a scale of 1 to 10, how motivated are you to quit? If this patient gives you a very high score, fantastic. So if they're giving you a high score in alcohol counseling or smoking counseling, your job is now to get them there. Talk to them about an alcohol, talk to them about the detox. All right, so which brings me back. When you're doing alcohol and smoking, another key question to ask in dependence would be, have they tried to quit before? What are the withdrawal symptoms? The reason why you need to know that is because that will affect your management. In alcohol, if the patient has tried quitting previously and they had actually gotten delirium tremens, then that would require you to give you a hospital detox. You can't do a home detox with this patient. You got to refer them in and you got to take care of them in the hospital, which is why knowing the withdrawal symptoms will tell you the direction of how you're going to take the consult. And if you're doing alcohol, the way to go forward will be tapering it down. They taper it down slowly. You drink less, 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 less. And if it's for smoking, you go cold turkey. This is advice you need to remember. Smoking, you want to stop, go cold turkey. Alcohol counseling, you taper down. So help them taper it down until they get to the ideal goal. There's one thing I wanted to mention, but I can't remember. And I remember. So for alcohol counseling, you need to remember to ask the awareness of your safe limits. That is a critical error. So safe limits of alcohol drinking, 2 standard drinks per day. That is your safe limits. Okay, so please remember that very carefully. Arrange and assist, just think a little bit more. If in an alcohol case, because alcohol clouds judgment, you need to tap a little bit on mood and a little bit on that your psychosocial history when it comes to alcohol. But smoking does not cloud judgment, so don't have to really focus so much on your mood or psychosocial aspect of it. Eating this, so we're going to move on to eating disorders and ECT. So eating disorders is only 2 types, bulimia and anorexia. BMI is the biggest giveaway because these people, some over the time, there tends to be an overlap in the compensatory mechanisms that these people do. So last time we used to say that there was no compensatory mechanism for anorexia people, but over time it's just been changing. So BMI is one of the better criteria to diagnose between bulimia and anorexia. So these cases come, someone did ask me about this. They do come with the dental caries in your mouth. They're referred by the dentist. Now, when they come in with that situation, your key history of presenting complaint is still your dental caries. So you need to spend time asking about the teeth problem, about the mouth problem. Is it painful? Do you have fever? Any ulcers in your mouth? Do you smoke? Focus on the mouth first. Try to rule out organic problems. Same as your body dysmorphic disorder. You try to rule out your breast problems, right? Cancer and big things. So same thing. Rule out your organic problems, and then you do psychosocial history. Go to the diet. So ask about the mouth or whatever presenting complaint. Then go to diet history. And then check how I also do a very quick LMP because these disorders can affect your periods. And if it's a problem, you need to bring it up in the management. So identify these things in the eating disorder case. They're very easy to score. Usually, if you can remember the SCOFF questionnaire. I usually send that before. I'll send it back to you guys again. The SCOFF questionnaire is used in eating disorders. So you just have to mention it in the management that I will be bringing up the SCOFF questionnaire for you. All right, in the management. Now, ECT, I'm going to tap on very quickly. So ECT is electroconvulsive therapy. When you do your ECT consultation, usually the patient comes to you because the medications are not working anymore and someone else, her son, comes and talks to you on behalf. And then you need to ask for power of attorney. Very big deal. Confidentiality, power of attorney, very big deal in psychiatry cases, in any case actually. So first you explain what is ECT. Then you explain to the son, why does your mom need ECT? whenever you have a counseling case, you need to make it back relevant to the situation you have at hand. So usually an ECT is given to you when your antidepressants aren't working, or you have hallucinations, you're psychotic, or you have suicidal tendencies. That's when it's an indication. So tell him that we're giving an ECT because the medications are not working as well for your mom. Your mom's not responding to medications. Therefore, we need to include ECT for you so your mom can feel a little bit better. And remember, because you're doing ECT does not mean you stop the medications. Everything goes in hand when you're doing your ECT counseling. So give your indications for ECT, explain what is ECT. The key word that we like to use for ECT is therapeutic jerks. We give you therapeutic jerks to rebalance the chemicals in your brain. To rebalance the chemical in your brain. So we give you a therapeutic jerk to rebalance the chemicals in your brain. That's what essentially it is. So they do go under general anesthesia for that. It's very fast. And tell them that you need a couple of sessions before they feel okay. So you won't see any difference until after about 4 to 5 sessions before you see a major difference in your mom. You need to get consent for that. And if mom is not able to decide whether she can go for the surgery, you can't consent for it, you get the mental tribunal court involved. Right, so that is your ECT. Talk about contraindications as well. So usually contraindications are recent MI, increased intracranial pressure are your contraindications. And then you can talk about post-care. How would you care for the patient post? So you'll be monitoring them. You have your multidisciplinary team. Talk about all of that. And of course, before the ECT, you would be doing an ECG. An anesthesiologist will be there to check on your mom. So mention that as well. So it's not a difficult case, ECT. If you know what to talk about, can be done very quickly. Very easy passing case, ECT. All right. Now I'm going to very quickly tap on MSE. Have a read, and then I'll run through very quickly with you guys. By now, I hope you've memorized the mnemonic AB septic J3R. Why do I always include the 3R, risk, rapport, and reliability? I know many organizations out there or tutors do not bring them in, but I bring them in because it's in the handbook. Very simple reason, it's in the handbook. And if the handbook is the only source that you have, just AMC has produced. So clinically, medically, you have to follow that as close as possible, except look for guidelines. So remember, when you are doing the MSE, appearance, behavior, speech does not hold a lot of marks compared to emotions and everything else below emotions when you're presenting the AB septic J3R. Many people spend so long talking about appearance. As long as the patient is dressed according to weather, dressed appropriately, nothing so weird about that patient, move on, done. Okay, nothing very weird, nothing very unique. Like many people, maybe they dress in very good colors, very bright colors, maybe they have a scarf around them. If there's nothing very significant in appearance, I would say move on. Because there is a depression case where the boy actually wears, I got that case. He was wearing a black hoodie, he was all covered up, black pants, black shoes, everything black, just sitting there, stooped posture, then that is something mentionable in appearance. But if there's nothing else to mention, move on. Don't waste your time, right? Behavior, eye contact, whether they are cooperative, and talk about their body posture. Now, speech, I know that again, other organizations have given you different ways to explain like quality and quantity. Too much to remember. Rate, volume, tone, enough. Okay, high, low, fast, slow. That essentially is what you want to mention in speech. It is only emotions and below your marks are very, very valuable, critical here. So emotions, when you want to explain the mood, take the exact word the patient say. Please do not make out your own word or own assumption. If the patient says, I'm sad, you say sad. If the patient says okay, you say okay. If the patient says so, please say so. Okay? Write that down at the top of your paper. You have to use the exact word because they will mark you down because you're not a good listener if you don't pick the exact words out. Affect is how you think. This is where your words come in as a doctor here. You can talk as much as you want. Or because it was congruent, not congruent. These are words you can use. In perception, you have all your hallucinations, so ask all your questions. If hallucinations are negative, which means there's no hallucinations in that particular case, you don't have to say there is no visual, auditory, tactile, olfactory hallucinations. Under perception, say no hallucinations found. So under perception, no hallucinations found. So whenever you're presenting your MSE, say the first word. In appearance, the patient looks. In behavior, the patient has eye contact and cooperative. In speech, so break it down for the examiner because you have to be as close to the examiner's marking sheet. That's the goal, right? And only if you break it down, the examiner knows, okay, she's doing this part, she's doing this part, doing this part. So again, in perception, no hallucinations are found. Yes, you can say it's normal, But the problem with saying normal is that now you don't show your clinical knowledge that you know that hallucinations fall inside perception. So you still got to be smart here. You got to show off your knowledge a little bit. You know hallucination is in perception. So say there's no hallucinations present. If you have time, then you can say all the different types, but highly unlikely you might have time when you're presenting your MSc. So then you move on to talk about your thought form and your thought content. So thought content, again, is what's inside the head of the patient, right? What they are thinking, the content of their thoughts. So all your delusions, all your suicide, all your different traits go in there. They all go into your content. Then in thought form, so you can say in thought content, the patient has um, persecutory delusions present. In thought form, the patient is speaking with loosening of associations. And then go on. Patient has insight. So insight, present, absent. Cognition. When you're explaining cognitions, use the word orientated, oriented to place, person, and time. That is the best way to explain. Don't say cognition present. What does cognition present mean? You ask place, person, and time. So oriented to place, person, and time. Judgment, the words to use are, is it intact or impaired? So judgment is intact, judgment is impaired. Enough. No need to dive so much. And then risk, rapport, and reliability. So risk everything, suicidal thoughts that you have. This patient wants to kill someone else. They're alcohol abusing. They don't know the safe limits. Domestic violence. All these falls under risk. And reliability, as I always say, history might be reliable, but that doesn't mean you cannot get collateral history from somebody else. So yes, history is reliable, but I would like to ask his partner a little bit more about the story, about how we can help him to change the management. So that's what I would recommend you to show that you're a very holistic person. I trust the source, but I want to find out a little bit more so we can better manage this patient. All right. And rapport. Rapport, some people say this. You must understand in schizophrenia patients, as long they are responding to you, there is rapport because they are answering your questions. It's not like they're ignoring your questions. And for schizo patients, the word that you want to use in behavior would be responding to external stimuli. Let me just type that down for you guys. Please remember this. If there's any kind of let me type it out. Okay, so use this. Responding to external stimuli. If you think that they're talking to somebody or they're feeling somebody, they ignore you here and there. It's not that they don't have rapport with you, they still answer your questions, but once in a while they're responding somewhere else and then they're coming back. All right. Any questions so far before I go to PE stations and I have a couple more, then we wrap up. Any questions? Any questions? If no questions, I'll tap a little bit on PE stations. I don't have too much about PE stations because, again, online it's very difficult for me to help you guys with PE stations. So, which is why I'm not a very big fan of helping PE stations. But of course, I'll explain to you. So, in PE stations, remember, in every station, you have to sanitize your hands before you even see the patient. So, you open the door, you go inside, examiner says, please sanitize your hands and wear your gloves. So, before you even go to the patient, you're wearing your gloves, you're done. You're done with wipe. You're done with W, wash hands and everything. So, it's very funny when now you practice deeply in your heart saying that hi there, Jamie, I'm going to do this examination for you. Let me wash my hands and come back. You've already done that. So you cut that out of your presentation when you're talking to the patient. The one technique that I always used was once I am someone who struggle with gloves. So if you've worked with me, you know that I don't like the gloves because my hands are so wet when I'm trying to put them. So one technique that I use is as I'm struggling with gloves, struggle coolly with your gloves, walk towards the patient, start your general appearance. Because general appearance, you're telling the examiner, patient doesn't care. So walk towards the patient, struggle with your gloves. On general appearance, examiner, I can see the patient is not distressed, sitting down well, no protective posture, not in pain. I don't see any kind of walking aids around, depending on your case, guys. Tailor your general appearance depending to your case, things that you would be looking out for. Then once you say your GA finished, you go towards your patient. You should have been worn your gloves fine by then. The gloves should be good. And I also heard that some of the candidates like to go for the extra large gloves because some organizations have told them that. But I also heard that some candidates said that the examiner scolds them. The examiner said pick gloves accordingly to your size, not get the big one, which means you have to go for your size. You can't put the big one very easily. So those are things that have been changing. They know the tips and tricks that we do, which is why we need to constantly update and upgrade our tips and tricks. all right, and adapt accordingly. So once you go towards your patient, do your general appearance as you're walking. So you don't have to stand in front of the patient when you're doing general appearance. As you're walking to your patient, you can already start your general appearance. Maximize your time. Once you're in front of your patient, hi there, how can I address you? Today I'll be doing this examination, whatever. The way you always explain. You can do that. All right. One asked what my size. Yeah, exactly. So they ask you for your size and they even point to the box. So I'm telling you, they are becoming a little bit difficult. Honestly, at the end of the day, they do try to make your life a bit difficult here and there. So we just have to be ready. If you are ready for the difficult, you won't panic. And if you don't panic, you know what, you're good. Do we just do gloves or sanitizer plus gloves? So they make sure you sanitize your hands first, then you wear the gloves. I know there's a trip on people putting the gloves first and then sanitizing. They're not buying that anymore from us. So sanitize first, hands will be wet, then you wear your gloves. Equals to more trouble, which is why I always say walk towards um the patient and do your general appearance to save time and look cool. And it's okay. You can still be asking her what is her name and still be wearing your gloves. Not a problem. It is not the end of the world if you can't wear your gloves. I struggle with my gloves and I still pass my PE stations, so it's doable. Okay, it's not a big deal. Um, Once you do all of that, make sure you get your positions right. Your CVS, you want to get your 45 degrees right. See if you need to shift the table up. Okay, make sure patient is comfortable during your PE stations. Now, one thing I want to mention, someone texted me. Let me find the question, sorry. One sec, one sec. I scribbled it, but now I don't understand what I scribbled. Yes. So this doctor asked me, can you advise about the ear PE? Now for ear PE, when you have to do your otoscope test. Now people are confused with this. Now AMC is bringing out the idea where they say no cranial nerves assessment to be done, or cranial nerves are normal, do not do it. But usually they will say don't perform any cranial nerves. Now, when it comes to fundoscopy and your otoscope and your Renes and Webers, you need to remember these are not cranial nerve examinations. These are your your hearing test, your ear ENT examinations, and specific to eye examinations. So if they say do not perform cranial nerves, well, you can still do your fundoscopy, you can still do your your hearing test, your otoscope, because it is not a cranial nerve. So get that idea right, because many of us memorize in cranial nerves. You get a headache case, you do fundoscopy in cranial nerve 2, and then in CN8, you do your otoscope and your hearing test. But they are not cranial nerve examinations. You're including them to establish, to make sure that cranial nerve is working. It's one way to identify if that cranial nerve is working, but that is not your cranial nerve examination. If you specifically go into cranial nerves examination, they are a bit more different. And cranial nerve examination involves different motor, sensory, and different examinations put together to create your cranial nerve examination. So which means you can still plug them out as a subset to do other things. So don't get confused with that. And remember, non-affected side first and then affected side. You have to compare both sides in MSK. So if you're doing your normal look, feel, move, now look, feel, move, you do on both sides, do non-affected side first. So use your advantage. When you're doing the non-affected side, explain to the patient, this is how I'm going to be doing it. All right, I'm going to shift your legs up, I'm going to bend, pull it forward for me, push against my hand or push down against my hand. So show how it's done using the non-affected side. Don't explain it and then do it on the non-affected and then do it on the affected. Waste of time. Explain and do on non-affected and then do it properly on the affected to identify what is the problem, whether it's motor or sensory, whatever is it. Special tests only do on affected side. Don't need to waste your time. Only do on affected side. Everything else, look, feel, move. Everything else, non-affected first, then affected. The reason why I'm emphasizing is because it's in the handbook and it's in Telly O'Connor. Handbook failed someone for not testing both sides of the shoulder for your shoulder examination, your knee examination. So remember those ones. Know your special tests really well. Special tests will help you even in your musculoskeletal examinations in PFI asking. Same thing. Copy and paste. No difference. Any particular questions about PE stations? That's the only much I remember. The other one I want to tap on is the mannequin and the human ones. But any other questions apart from the mannequin versus patient? Continue putting in the chat box. I'll just run you guys through the mannequin. So usually the logic is very simple. If you have a role player in front of you and it's a heart failure case, I always use this. The patient is not going to have heart failure. They're not going to bring a heart failure patient to you. So if when you are doing that auscultation, you are not going to be able to hear your S3 and your gallop. It's very rare you can hear that in a patient. So that's why when you are doing a physical examination on a patient, it should be I am looking for. So I am looking for. S1, S2, S3 in a gallop rhythm. Then examiner will then tell you, if it's a positive, examiner will come and tell you, yes, there is a gallop rhythm present. So you have to say what you're looking for. However, if you have a mannequin, now the mannequin has already been designed to give you the correct answer. Mannequin has already been planned and prepped. If you're doing your year PE, mannequin already has your cholesteatoma inside. Mannequin already has your foreign Rex body inside. You look at it, you know exactly what it is. So, which is why in the mannequin, when you're doing it, the examiner will say, tell me as you see. So you look into it and say that I can see, or I am looking at, and or I cannot see, because the answer is there. You're not telling them everything over the sun because you're waiting for a positive from the examiner. The mannequin already has the positive. And now when they tell you about commentary to examiner, please remember, mm, mention, say, call the examiner out. So examiner, I'm looking for, and the patient name is Jamie. Jamie, can you please do this for me? Can you please do this for me? Okay, examiner, I'm testing for crane of C5, C6, C7, checking for power. So practice doing that. You need to be able to tell the examiner and then tell the patient, give the instructions to the patient. It has to come a little bit flowy. For those of you guys have time, try to make it a little bit flowy. Any questions for PE stations? The last part is very for everybody. So that is there's no other content that I'm trying to put into your head anymore. The last part is just the what to do for the last 2 weeks that you guys have, or last few days that you guys have. So no more content. If any other content questions, you can text me text in the group. I'll reply you. Usually once I see 8 July questions, I can roughly tell you what's the runway a little bit. If you've seen I've been able to see a bit like here and there. I can tell you guys a few. So I've given you guys a long list. So read up, make sure you know about the long list. STI definitely will come. MMSE definitely come. MSC definitely will come. So those are not very big problems. But I have to wait. Oh yes, it's an MMSE. I remember. I have to wait for the rest. All right. So let me just do the MMSE really quickly with you guys. Now, for the MMSE, you always will explain it's a screening tool to the patient. It's a screening tool to identify your cognition, okay? And then once you're done explaining what is it, get consent from the patient to do it. And remember, when you do the MMSC, it's a mini mental state examination. It has a score of 30. It will only be done, take 5 to 10 minutes to do the entire thing. And when you're telling that to the patient, remember that when you do the MMSC, it has the recall aspect of things. You have the registration, you have attention in your MMSE presentation. MMSE questioning. So the first few questions are very easy, tells you about orientation, so where you are, what you're doing. And remember this, whatever words you see in the MMSE, say exactly what you see. Please do not add in your own words. You will be biased. You will make the MMSE inaccurate. So say exactly what you see. Give me a second. Let me just plug on an MSC for you guys, all right? I'm going to stop share for a bit um, and pause. Please. Okay. All right. So now, please, say exactly what you see. If it says what year is this, ask what exactly, because everything has a point. Do not skip. You're going to, it's inaccurate if you skip. So follow through all the way. Ask exact words. Now, people have a problem here. If this one says, I am going, say exactly what you see, guys. Do not. This is where people have a problem in this task. I'm going to work on this number 3. So say I'm going to name 3 objects when I'm finished. I want you to repeat them. Wada. You got to say ball, car, men. Then ask, please repeat the 3 items for me. And let's say your patient says ball, car, let's say patient can't remember the third one, men, right? Your job is not to say men and help them finish it up. You have to repeat from the beginning. Ball, car, men. Let the patient repeat again. And then if the patient stops at car this time, say all 3 again. Okay, it's error if you say just the one they are missing, and then write down the number of times they're able to say the attempt correctly. Usually, so far in the MMSE, they have not gotten you to score it. They only make you do the task, so not a problem. Now, this is the old version of the MMSE for task number 4. We usually don't spell the word world because it's confusing. It's just spell world. Okay, and then get them to spell it backwards. So follow the exact task. There are differing versions of this. There's a standardized version and a non-standardized version. So it depends the one that you have on your table at the end on the exam day. Say exactly what you see. Now, then you go back, this is where you have your recall. So now here, if they have a problem with task number 3, right, it would be a problem of registration. They are not able to register what you have just said. So it's a registration problem. But now we go here, this task number 4, they're not able to say this word. It's an attention problem. They're not able to be attentive enough to pick out and tell you the words of the spelling. And if they have a problem with this one, with task number 5, that would be a recall problem. So these are the ones that are more commonly coming up in the AMC. It's either a recall problem. So if task number 5 is a problem, it's a recall. If not, it's a registration, hard to remember for them. Or they have not attentive enough to be able to spell the word world backwards. So the common cases which come up for the MMSC would be the alcohol-induced brain injury. This lady has been drinking for 20 over years or 30 over years. So alcohol has affected her brains, and that has caused her to have alcohol-induced brain injury, leading to a problem in recall, registration, and attention. That is your very commonly occurring case most of the time. One more thing, don't be afraid if someone has a normal MMSC, because at the end of the day, I can present an MMSC on you and you can present it on me, and we'll probably have good MMSC scores. We've got 30 upon 30, right? The other ones are a little bit easy. For task 7, all these things will be provided, so don't panic. They will be provided. And this one, exact same sentence. I would like you to repeat a phrase after me. No ifs, ands, or buts. Say it slowly, say it clearly. And people always confuse themselves with task number 9. All right, so read the words on this page and do what it says. That is why you tell the patient. You have to write these words, guys. Close your eyes, all right, on the paper. Write it big, write it clear, write it all in capital. If you see capital, write it in capital. You see small letter, you write in small letter. Write exactly what you see on that paper, all right? And then you tell the patient, repeat these words on this page. Do what it says. So ask the patient to say it and then read it, sorry, not say it, read it and then do what it says. Some people, when I do this task, they get very confused. So if you're not practiced MMSE before, you're going to be very confused. So get them to close your eyes. And one more thing, I have a very cute candidate who used to put the paper in front of his face, and now he can't even see the patient closing the eyes, and he's just holding it there. And patient is also closing the eyes. So please put it at the side of you. Make sure you can see the patient doing it. There's no point if you can't see the patient closing their eyes. All right. So please don't forget that. Usually they don't ask you to do 10, 11, and 12, but read the task very carefully. They tell you it has been scored. They tell you do not do the last 2 tasks. Sometimes they stop you. Sometimes examiners are not very kind. They're just going to watch you make a mockery out of yourself and waste your time. So read the task very carefully. Don't really struggle on calculating something when they've already told you to not calculate. All right. Now for the rest of us who have time, sorry, I want to stop the recording and re-record because I'm going to post this as a different video. Just give me a minute because some people are just